All right, my clock is saying that it is 8 o'clock on the dot Eastern time. So we are going to go ahead and get started. Good morning, I am Lindsay Denny, and I am part of the Secretariat for the Washington Healthcare Facilities Community of Practice. I am normally joined by two colleagues, Dr. Joanne McGriff and Haley Elling. Unfortunately, neither were they able to participate today, so you just have me organizing this session. And we are here today to talk about the JMP data. And so we're so grateful to have Dr. Rick Johnson. And actually, we also have his colleague, Tom Slaymaker, here on the call to learn about the JMP data from Washington Healthcare Facilities, and then looking forward to a discussion about how we leverage this data for action. So I'm going to go ahead and start with a brief overview presentation about why we're here, and then I will hand it over to Rick. So again, this is leveraging JMP data for action, presented by WHO's and UNICEF's JMP Joint Monitoring Program for Water Supply, Sanitation, and Hygiene. Just a quick note, this session is being interpreted. So if you would like to hear this session in French or Spanish, please select the interpretation world and choose your language. We may end up during the discussion section having people speak in French or Spanish, so I do encourage you to click the English session just so you can make sure you hear throughout this session. Quick note of who we are. This is a community of practice that is action-oriented learning platform, bringing together Washington health communities to focus on the evidence, practice, and policy related to Washington healthcare facilities. And our goal really is to connect partners, share experiences, and encourage groups to act. And this community practice is in our second year. This is technically our second event of the second year. So really looking forward to those of us who are joining us for the first time. And then in terms of this community of practice, we do have some basic principles that we follow, and this affects how we choose our speakers, our topics, and even how we format our sessions. So the first principle is that WASH is a fundamental prerequisite for quality of care within healthcare facilities, and there cannot be effective infection prevention and control without adequate WASH. Secondly, Washington healthcare facilities is a solvable issue, which requires multiple systems, sectors, and stakeholders to work together to see sustainable improvements. This is an issue that falls between multiple systems. We all need to work together. And lastly, the community of practice is open to all who seek to learn and share about Washington healthcare facilities. We welcome all and respect the diversity of participants who participate. So every time we have one of these sessions, we do want to bring a new resource to your attention. And this week's research is actually not a Washington healthcare facilities resource, but I think is really important for those of us looking at infrastructure and healthcare facilities. Last month, there was a new global report on healthcare facility electrification that was released by WHO in partnership with ARENA and World Bank and SE for All. And it found that more than 1 billion people are served by healthcare facilities without reliable electricity. It presents data from electrification of facilities in low and middle income countries, and also projects investments required to achieve adequate and reliable electrification of health facilities. Why are we talking about this? I think it's really important for us as Washington healthcare facilities actors to think about the other partners in the facilities. How do we not take a siloed approach to this issue? Can we reach out and work with those, for example, working on health facility electrification to make sure that we have the basics in place to deliver safe care for all? Certainly, safe care for all cannot be delivered without WASH, but the same could be said for delivering healthcare facilities without electricity. So worth taking a look at this report. It has some really interesting information in it, breaking down by region, and we'll hear more on that in the future in terms of potential partnerships. And then last but not least, we'd like to highlight success. I know it can feel a bit like we're just dragging along, and it's hard to see above the grass here to see how we are succeeding. So we like to bring specific stories from our partners. And this week is from UNICEF Vanuatu. They have been integrating disaster risk reduction and climate change adaptation into their Washington healthcare facilities assessments and planning. They use a national Washington healthcare facilities assessment tool, which is based off of WASH Fit and some water safety and security plannings called Washington Health Kia. And when they facilitate this tool at the facility level, it triggers a disaster risk reduction actions while also setting infrastructure standards in place that are climate resilient. And this is a really participatory action that they pull together through both members of the community as well as the healthcare facility itself. This tool has been contextualized and tested in multiple provinces and will be used to develop climate-sensitive improvement plans to support the upgrade of healthcare facilities to have resilient WASH services. You can find this tool on the washandhcf.org. It is in the local language, so it may not be the most useful for those of us who aren't working in Vanuatu specifically as a tool. But I think what's really interesting about it is thinking about the application of WASH Fit in this context. So I think it's really great to look at as a lesson and success story in that context. So with that all being said, I'm going to go ahead and stop sharing my presentation, and I'd like to hand over to Dr. Rick Johnston from the JMP to tell us about what the data is for Washington healthcare facilities.
Yeah,
over to you.
Thanks so much, Lindsay. It's a pleasure to be here. First of all, can you see the screen that I'm trying to share?
Yes, we can. Looks great.
Okay, super. So I'm Rick Johnston. I'm with WHO in Geneva, and I co-lead the joint monitoring program with Tom Slaymaker at UNICEF, who's also on the call today. Yeah, people could just mute their microphones if they're not speaking. I'm getting some noise. Well, the JMP has been publishing reports on WASH in healthcare facilities since 2019. And today I wanted to share some of the highlights of the report that we published in August last year, which is the third global report now that we've published on WASH in healthcare facilities since the first one in 2019. So let's see, there we go. Gosh, you know. There we go. So this new report, well, it updates and supersedes the data from the early reports, including the 2020 Fundamentals First report. And that report was pretty short. It only included about 20 figures. It was one chapter in a part of a larger report that the JMP contributed. Whereas this 2022 report, it's a full-scale report. It's got about 80 figures, and that allows us to go into a lot more detail beyond just the basic indicators and explore, for instance, inequalities or things that go beyond the basic service levels, which we didn't have the time or the space to do in 2020. And one thing that I get excited about in this report is the amount of data sources that we draw on. It's expanded a lot. We had access to over 500 national sources of data, and most of these are healthcare facility surveys, but we also have several examples from routine management information systems, or MIS, and a small number of sector reports or other research studies. And together, these data sources represent assessments of at least 933,000 healthcare facilities. That's up from just over 500,000 in the 2019 baseline report. And we think that it's actually a larger number because some of the sources don't tell us how many facilities they sampled to collect their data. Well, for each of our reports, we make use of service ladders to monitor progress towards different levels of WASH services. So for households and schools, we have ladders for water, for sanitation and hygiene. We have those for healthcare facilities as well. But in addition, there are ladders for healthcare waste management and environmental cleaning, which are both related to hygiene and infection prevention and control, specific to healthcare facilities. So the ladders include definitions of the basic service level. That's the highest level that we track for global monitoring. But that doesn't mean that that's the highest possible level. These basic service levels really are quite basic. So we also highlight in our reports where data are available, examples of countries that are monitoring higher levels of service. Lower in the ladder, we try to distinguish between facilities that have no services at the bottom of the ladder there, and facilities that meet some but not all of the requirements for basic services, and we call those limited services. Now, this report had a special focus on infection prevention and control, or IPC. We're very excited about that. It was topical with the whole pandemic, but there are a lot of reasons why WASH and IPC are important for each other, and we wanted to explore those systematically. A lot of our audience come from more of a WASH background than a health background, so we wanted to point readers towards frameworks and resources from the health sector on IPC. For example, the IPC has what they call 8 core components of IPC programming, and one of them is about infrastructure, and it includes WASH services. So within the IPC literature, then, there are minimum requirements from an IPC perspective for each of those 5 service areas. So we reference those, we cite those in the report and try to find data examples of those. Also in 2022, there was an important global report on IPC, the one with the little blue tree there. And that included data from the first WHO global survey on IPC in healthcare facilities. So we also reference that and show some of the WASH-related data from that report. Now, this figure shows bars from the 3 reports that we've published, showing the numbers of countries that have data for the different basic service indicators: water, sanitation, hygiene, waste management, and environmental cleaning. And the different shades of gray represent different income level countries. You can see that there's a lot more data available from low and lower middle income countries than from especially high income countries. But you can also see that there's been a solid progression among the 3 reports. Data coverage is the lowest for environmental cleaning. That's the newest of the indicators, but it's really been increasing steadily from report to report. Now, the colored circles, they show the evolution in the proportion of the global population that has data. So if we look at water on the left, we can see that the number of countries with data on basic water services has increased from 38 to 52 and now 59. That's great. But the proportion of the global population with data hasn't really changed much. It's around 37%. And that's because the new countries that have been added were small in that case. But we do see strong growth in the population with data for the other indicators. And if we look at hygiene in particular, we see that it crosses above 30% for the first time in this report, at 35%. And that's important because the JMP has a rule where we won't publish regional or global statistics unless they draw on real data from at least 30% of the relevant population. So that means that we could, for the first time, produce a global baseline for basic hygiene services, along with regional estimates for 3 of the SDG regions, and for fragile contexts, and for least developed countries. In fact, we organized our report to lead with hygiene this time. We have started with water in the past, both because we have a new global baseline and because hygiene is so central to IPC with the special focus of the report. You can see the definition of the basic hygiene service up there. It's about having water and soap or alcohol-based hand rub at points of care, and also having water and soap available at or near toilets. So while it's good news that we have enough data to make a global estimate, that global estimate is actually pretty bleak, that just about half of healthcare facilities had a basic hygiene service in 2021. And that just means they had functional hand hygiene facilities at points of care and water and soap at toilets. It doesn't even mean that they were used, just that they were available. We can also see some important differences among the regions. For instance, in the 46 least developed countries, coverage is the lowest, with only about 1 in 3 healthcare facilities having a basic hygiene service. Now, the report and the individual country files can be downloaded from our website, washdata.org. But you can also make your own graphs on the website. I encourage you to visit it at the website above there. And this is an example of, it's called a rank chart for the basic hygiene services that shows that we had 40 countries with enough data to have basic hygiene services in healthcare facilities, ranging from a number of countries with universal coverage, 100% or nearly 100%, down to a few countries below 20%, and Niger even only at 4%. So there's a lot you can do by exploring that website to learn more about countries that you're particularly interested in. We also highlighted good examples, and of course, the COVID pandemic drew special attention to hand hygiene in healthcare facilities. And in Ghana, they have a very impressive routine MIS system called District Health Information System, DHIMS, that's been collecting data on basic hygiene since 2018, so before the pandemic, when the global indicators were first defined. And this allowed people, the planners in Ghana, to know exactly which facilities did and didn't have basic hygiene services when COVID hit at the beginning of 2020. So the Ministry of Health used this data. They acted quickly to reinforce systems in healthcare facilities. They held trainings of IPC focal points, encouraged the use of simple hand washing devices, and made sure that water and soap were available when needed. And as a result, we could see coverage increase from 41% at the end of 2019 to 57% in mid-2021. So that's going up by 16 percentage points in just a year and a half, which is pretty remarkable. You can also see that the facilities with limited services declined over the same period, but there's a small number of facilities, about 2%, that still had no services, and that remained pretty stable. Okay, if we turn next to water, as the other service area where we have enough data to make global estimates, we can see that in 2021, 78% of healthcare facilities had water available from an improved water source on premises, and the remaining population was split evenly with 11% limited services and 11% with no service. If we look at the regional distribution, we see lower coverage in sub-Saharan Africa, just about half, 52%, and much higher at 90% in Eastern and Southeastern Asia. So there's a big difference, though, between having an improved water supply and having a basic water service. So the definition of basic water service means you have an improved water supply, but that water is actually available and that improved source is located on premises. So this graph shows the gap between improved, that's on the right, the hollow circle, and basic, the filled circle on the left, and it can be very large. If we look, for instance, at Iraq, their census in 2021 found that nearly all healthcare facilities had improved water supplies, and they were pretty much all on premises, but water wasn't actually always available. In fact, in a quarter of facilities, water was available for less than 5 days per week. And we see this often in countries that have emerging piped water systems, but not yet continuous and can be highly intermittent. On the other hand, if we look down at the bottom of the graph at Sudan or Sierra Leone, the limiting factor is really where the water supply is located. That's the X. On premises, it's quite low. So in both countries, over 80% of healthcare facilities had access to an improved water source, but it's most often a borehole or a protected dug well that isn't located on premises. So it makes it difficult for healthcare workers and patients to get all the water that they need when it has to be brought in from outside. Back to the website, we saw earlier how to make a rank chart about basic water services, but there are all these controls on the left-hand side of the screen there. So you can also look at improved supplies or those elements of the basic services, like is it available on premises? Is water available when needed? You can also select different regions. So here we're looking at sub-Saharan Africa and looking at the proportion of healthcare facilities that have water supplies located on premises, improved water supplies on premises. So again, you can find out a lot of detailed information by navigating this data portal on your own. Environmental cleaning, that's the newest of the WASH service ladders. It's also very closely tied to infection prevention and control. And because it's new, we don't have as much data on it. So the definition here is just about having basic protocols for cleaning available and having staff that have cleaning responsibilities that have all received training in how to conduct the cleaning. And when we made our first baseline report in 2019, there were only 4 countries with national data on environmental cleaning. So it's now gone up to 21, which is great, but it's still not enough to make any kind of global or regional estimate. But we do have countries from different regions in the world. So we can see that in many countries, protocols for cleaning are not available, or if protocols are available, there's not always staff responsible for cleaning or who have received training. So Here you can see, for instance, that in Northern Africa and Western Asia, we have a really widespread. We've got Kuwait at 100%, and Sudan having only 1% of facilities having basic environmental cleaning services. So because there are two elements to this indicator, there's having the protocols and having the training, one or the other of them can be the limiting factor. And this graph shows that sometimes it's the availability of protocols. So in the upper triangle, you see Bhutan there, where about 45% of staff are trained, but only about 20% of facilities have protocols. So they're trained, but without protocols. Whereas in Rwanda, then this is a more common scenario. Protocols are available, but either people aren't identified who are responsible for training, or they haven't received training according to those protocols. Let's move to healthcare waste management then. The service indicator here has two components also. It's about having waste being safely segregated at the point of generation into at least 3 bins, and having wastes, both sharps and infectious wastes, be treated and disposed of safely. And again, here you can see one or the other of those could be the limiting factor. This graph also shows the income level of the countries. So you can see coverage is quite high among the diamonds and the squares, the high income and the upper middle income countries. But there are a lot of middle income countries, middle, upper middle, lower middle, squares and diamonds, squares and triangles, where waste is segregated, but it's not safely treated and disposed of. And one reason for that is that there's an awful lot of burning that goes on, open burning in middle income countries, and that doesn't count as safe treatment for global monitoring, but we do find that that's very widespread. But there are also countries where waste is being treated without being segregated. So on the far left there, you can see the Democratic Republic of the Congo and Guinea-Bissau, where there's almost no segregation at all, but about half of healthcare facilities do have some systems for treatment and disposal. This is often incineration, but of course it's inefficient to incinerate non-hazardous waste along with hazardous waste. It's wasteful. It's also dangerous because, especially in lower temperature incinerators, toxic furans and dioxins can be formed when plastics like that are burnt. Going back to our web page here, our data portal, this is an example of how you could look among least developed countries and see the different levels of service for different types of facilities. So we can look at urban or rural facilities. This graph is showing government facilities, and we had about 24 countries globally that had data on basic services in government facilities in LDCs. So that's about half of LDCs. There were only 12 LDCs that had data on non-government facilities. And where we do have both of them, we often find that conditions are better in non-government facilities in the same country compared to government facilities. I mentioned that there was a lot of open burning. Here you can see from, what is it, about 10 or a dozen countries. All of these orange colors here are some kind of open burning in a pit or on the ground without protection, or just open dumping. That also doesn't count as a safe treatment and disposal practice. The red ones, whether it's removing something off-site or dumping it without burning in a protected pit or ground, that counts as safe management, or incinerator. And ideally, we would like to see incineration in a 2-chamber industrial incinerator with controlled and high temperatures. But for global reporting, we also take more simple 1-chamber incinerators. So the last and the most complicated of the 5 services is the sanitation. So you can see just from the definition that there are lots of factors here. We're talking about having improved sanitation facilities that are usable, but also where there's at least 1 toilet dedicated for staff, a sex-separated toilet that has menstrual hygiene facilities, and at least 1 toilet accessible for people with limited mobility. So the figure on the right shows all those different criteria, and you can see that a lot of healthcare facilities on the left have some kind of sanitation facility or improved sanitation facility. But as you get to the right, the coverage really drops off. And it's often, especially having facilities accessible to those with limited mobility, or having menstrual hygiene facilities where the coverage is the lowest, and that ends up determining the basic sanitation service level. We don't have enough data to make a global estimate here, but we do have enough coverage to provide regional estimates for 3 of the SDG regions. And you can see quite low coverage, even in Northern Africa and Western Asia, less than half of healthcare facilities having basic sanitation, and only 13% in sub-Saharan Africa. As a quick example of going beyond the basic service levels, people are sometimes surprised to see how much non-sewered sanitation there is in healthcare facilities, even in hospitals. But this graph shows on the kind of the right half there, septic tanks and improved latrines, and on the left, sewer connections. And in most of the countries with data, these are low and middle income countries primarily, on-site sanitation is much more prevalent than sewered sanitation. And I wanted to just highlight these 4 countries here that have only about 8–10% sewer coverage, but something like 40–50%, up to 90% coverage with on-site sanitation facilities, because we had a little bit more data here to show how things were managed in those settings. So if we start with Oman on the top right, everything's great. All of these on-site systems were safely emptied and taken to treatment. Oman's a high-income country. But if you look at all the other 4 of them, there's a really small percentage, it might be single digits, it might be 20% where the tanks are safely emptied. A lot of them, they're just not emptied at all. And of course, there's something wrong in the design and operation of a septic tank or a pit latrine if it's never been emptied in a healthcare facility. These things need to fill up. You also see that safe emptying tends to be higher in hospitals compared to non-hospitals, smaller healthcare facilities, also higher in urban than in rural areas. Okay, so then just to conclude, that's a lot of different service levels. People sometimes want to know, well, what's the overall WASH figure? And we haven't been able to integrate all 5 of them, but there are some regions where we do have 4 of the ladders, so least developed countries, fragile contexts, and sub-Saharan Africa, and they all look more like this figure, which is for LDCs, where water is the highest, hygiene and waste management are maybe a third, and sanitation tends to be the lowest for the basic indicators. There are 16 countries where we do have all 5 ladders available. You can see them here. And that same basic pattern follows. Basically, the basic water service level is just an easier service level to reach than, say, the basic sanitation or even the basic hygiene service level. So we consistently see this pattern where basic sanitation tends to be the lowest. But in some cases, environmental cleaning can be the lowest. There can be some really interesting distributions. So the types of interventions that would be needed to accelerate or to improve WASH in healthcare facilities could be very different depending on which service levels tend to be better or worse in a given country. So with that, let me turn it back to Lindsay, and I'm looking forward to having a discussion about not just monitoring these things, but making use of the data and improving services in countries all around the world.
Thank you so much, Rick. Big round of applause here. I'm sorry you can't be in person to hear us cheering for you, but always fantastic to go through the data. I always learn something new and really interesting to think. I was thinking this morning back to, in 2015, when we launched the status report, this was not done by the JMP, I realized, but that had 66,000 facilities. And in the time since, the JMP has created the core indicators, has launched a baseline and 2 progress reports, and we're now at over 900,000 healthcare facilities included in this. So I think just seeing the progress in 8 years to where we go, if we think about maybe a blurry picture we had of what the conditions were and the situation was in healthcare facilities 8 years ago, it feels like we're getting this much clearer understanding, particularly I think on that last slide where you were showing in some countries, we can see what the situation is with basic water, basic sanitation, basic hygiene, and to kind of look at, is the problem all in certain facilities? Is it across the board? We have lots of problems. And I think that's a really interesting way to start thinking about the data rather than just in siloed water or sanitation. So thank you so much for this presentation. I'm going to see if we have any questions here in the chat box, or please feel free to raise your hand. We'll be monitoring that as well. And Rick, we can still see your screen, just so you know. There you go. So if anyone has any questions here, I see some comments here. First of all, you're getting kudos for the JMP website. Some great feedback here on the use of it. Does anyone have any questions on Rick's presentation? I know I have a few, but I want to see what folks are thinking here. Give a second here. So a question from we have here from Francois, but I think I'll wait on this because it's linked more to Wash Fit. Okay, here we go. A couple questions here in the chat. I'll start with Darcy's question. Darcy is curious at the distinction between a hospital, what is a hospital and what's not a hospital?
Oh, I thought when I started this, I thought this would be easy. We were just like, this is WHO, right? We must have a definition. We don't have a definition of what a hospital is. And countries have their own definitions of different types of healthcare facilities. So a lot of healthcare facilities are classified as hospitals. Some are classified as like clinics or polyclinics or health posts, or there's a whole range of terms that get used to describe healthcare facilities. And basically what we do is we say if it has the word hospital in it, then it counts as a hospital because it's matching some national definition that has to do with the level of service that's provided. But it's not like there's a global definition. We had hoped to have at least 3 levels to get at something about the size, but looking at the way that different countries were classifying the facilities in the assessments that they made, just hospital and everything else was the best that we could do.
And non-hospital is a great catch-all term for everything
Isn't it a horrible term? I hate this term.
No, but we understand where that comes from. That's helpful. I've got another question here from Ryan asking about, as we've seen evolutions of ladders for water and sanitation services since the MDG monitoring, wondering how you see the evolution of the ladders for these new areas, solid waste management, I assume he means healthcare waste management, environmental cleaning, hygiene, et cetera, in the healthcare setting.
Yeah, well, I mean, of course, the big difference between the ladders that we have in healthcare facilities and those that we have for households is that they only go up to the basic level. So in the transition from MDGs to SDGs, of course, we added safely managed services to the household drinking water and sanitation ladders. And there's a lot of interest in what that would mean in healthcare settings for these 5 ladders. And it might be that at some stage, there would be a global consensus around what would be a minimum set of requirements to get to that level. But because at this stage, we're still kind of scrambling to get data coverage even for these basic levels of service. And the data show some pretty disturbing news, even looking at the basic level of services. So at this stage, we're not in a position to think about what like higher levels of service might be for global purposes. But in our reports, we do try to call out examples of countries that are monitoring things like drinking water quality or actual hand washing practice or management of fecal sludge in those on-site sanitation settings. So there's a whole bunch of different things that go beyond. And I guess our approach is where if we find a nice example of a country that's doing monitoring that goes beyond basic and there's some nice data story, we love to highlight that in one of these full reports. And maybe at some point in time that could result in a higher level of service being reflected in the ladders. But I think that would be a way off.
That's sort of what I was going to ask, was the advanced service levels, whether or not we have good examples of how different countries are defining that, and maybe down the line that could help us think about what safely managed looks like.
And I think it'll probably be different for the different ladders. Like we have a nice example we highlight in the report of Serbia that did a really in-depth assessment and did want to define higher levels of service because the basic services were largely met, except for sanitation, because they had a lot of work to do even to get to basic sanitation. So they added things like drinking water quality. Legionella is particularly an interest in a lot of healthcare facilities. So they wanted to capture that in their advanced services for water. So we do collect examples and show them. So other countries might say, oh, that's interesting. I'd also like to monitor that kind of thing.
Fantastic. Got two more questions in here for you. The first I'll start with is from Myrna, talking about examples of countries that have experienced more considerable progress compared to others. So maybe a question first, Rick, is whether or not you're able to see progress in any countries. And secondly, if so, are we able to maybe do a little bit of a deep dive in any of those countries to understand what we see is taking place?
Yeah, well, unfortunately, we don't have a strong enough database to talk about trends for many countries at all. In fact, for some countries, we're still only having 1 or 2 data points for some of the different service elements. The Ghana example I shared about hand hygiene was one of the exceptions where they do have a rich time series, not just for hygiene, but for the other indicators. So there are a couple countries where we can look at trends like that, but by and large, we don't have many data from these routine data systems. It's more facility surveys, and facility surveys are expensive, and we just don't have that many where we have 2 or 3 points to really talk about evolution.
Fantastic. We've got a comment here from a couple of folks from Nigeria. Ulufemi is asking about Nigeria's disconnect between the National WASH Survey reports and the JMP. And Bright's commenting that looks like the data is coming specifically from a certain 2019 report. So maybe my question for you, Rick, is about the way you use these data, as you're talking about where the data is coming from originally, and why people might be looking at this and not seeing certain data sets that they know exist in their country.
Right. Well, one thing I should have said at the beginning is that the JMP tries to collect all available national data sources on a topic in the country and extract from those data that are compatible with the global indicators and definitions. But then we take all of those that are available, and I mean, I said that it's rare to have multiple data points, but if there are multiple data points, we put them in a linear regression and get estimates for all years then, even so we wouldn't necessarily have the same results as an individual survey report, for example. Also, sometimes individual survey reports use definitions or methods that aren't quite aligned with the global ones. So you might have different figures reported, but if you dig into the definitions, you would see that maybe they're reporting a slightly different indicator than the global ones. So I'm not familiar with this particular report, but those are 2 reasons why there might be differences. The use of multiple data points and the differences in definitions or methods.
No, it's really helpful to hear. And I think also, I know that you engage with the countries to talk about the data and validate the process. So that's also in terms of how you get the data sources. There is a conversation back and forth, for example, with Nigeria.
Every time we update the global data set, we compile all those data sources, but then we send them to the countries and we give them a couple months to review and say, you know, are we missing anything? Have we made any mistakes? And to get their feedback on the estimates before we finalize them. So there is definitely an important process for countries to review and comment on the estimates.
Exactly. So it is possible that the countries themselves may not have had sent on certain surveys to you. All that to say. Yes,
I mean, so if there is a survey, we hope that we would find out about it either through the consultation or through the WHO and UNICEF offices that are mobilized when we're preparing a new report. We do update the global database every 2 years. So, you know, the cycle keeps moving. So at the end of this year already, we'll have our next country consultation. So if there are specific data sources that anyone on the call knows of, you know, send them to us and we'll make sure that they get into the next update.
Fantastic. One last question here from Stannis is asking about the measures that JMP takes to have sufficient data in order to have an idea of the evolution of environmental cleaning.
Well, again, we can talk about the evolution of data coverage, but right now we only have 21 countries, so we can't say anything about like the evolution of the status of environmental cleaning. And we are really data poor on this one, so it's really hard to say even within an individual country if there have been improvements on environmental cleaning. It is the kind of indicator that I think should be possible to move the needle quickly on, because it's really more of a management focused indicator. You don't need big infrastructure or big budgets to get protocols in place and to train staff. So I hope that we will see impressive progress on this one, but it's going to take a while until we have multiple rounds of data to see that kind of progress.
And for those who aren't aware, the environmental cleaning indicators, if I'm not mistaken, Rick, are ones that were actually written specifically for the JMP. They aren't likely to be in people's surveys already. They need to now be added to facility assessment. So that's why we probably don't see the amount of data that we do with, for example, improved water sources.
Yeah, when we were developing the global indicators, we went through a process and we brought together a lot of experts to say, well, what would the basic wash service levels be? And there were some data around, water, sanitation, hygiene, and waste management, but it kept coming up that environmental cleaning is really being left out, and we really need an indicator for that. So yeah, that was in a sense a newly crafted indicator. It is catching hold now, but it takes time to get into data management systems.
Absolutely. I want to turn to Tom and see if you had any thoughts you wanted to add to any of these questions or comments we've had from the group so far. Sorry to put you on the spot, Tom. You're just here and I see you in the chat.
I think Rick's done a great job answering those questions. I just typed an answer on Nigeria. I think Nigeria is a really good example of where we have quite a comprehensive assessment, which is going on now, not just households, but schools and healthcare facilities. And that's happening quite regularly. So we are starting to see information on trends in Nigeria, and that's very positive. But we weren't able to include data from the most recent round of surveys in our last progress update, which is perhaps why there's a discrepancy between our estimates and the latest survey report.
Helpful to remind that there is a bit of a delay there between when the data is available and your ability to assess it. I'm going to quickly open up a poll before we switch into more of a discussion around how we use the JMP data. This has been really enlightening to understand more of the nuance of the JMP data and what we're looking at. I think understanding the difference between just getting enough data around the current status versus, to Rick's point, being able to talk about trends. We're not quite there yet. But I'd be curious to know, first of all, have you looked at the JMP data for Washington healthcare facilities? I don't necessarily mean the most recent report, though I certainly hope that after this conversation, you'll go look at that report. We can drop the link in the chat, but also looking at the data from, more generally speaking, from 2020, the 2019 report, et cetera. And if you have looked at the data, how did you utilize it? Was it for background information? Were you using it in proposals, advocacy? Have you used it to leverage research? Implementation? Are you using it to help develop monitoring systems in your country? HMIS certainly might be pulling from some of these, not data, but certainly from the data, the indicators that the JMP's put together. And then if you have other, drop it in the chat. We'd love to know how you are. I'm sure Rick and Tom would love to know how you're using the data. So please let us know. Thank you, Rick, for putting that link in there. So I'll give you guys another 30, 45 seconds, answer the question. And then we'll share back. I know it is, these documents are never small, so that does take some time to go through, but hopefully Rick's, kind of taking us through each of these sections helps you digest this. And there's a really fantastic executive summary section in the report that you can kind of get some of those key messages, and then you can dive deeper, looking at some of those graphics that they've put together. And some of the ways in which they break down, for example, hospital versus non-hospital, rural versus urban, and what the data is telling us. So take another 20 seconds here, see a few more folks answering the question. And then I would love to hear more as we look at this about those of you who are using the data for various purposes. So I'm going to end the poll in 5, 4, 3, 2, 1. All right, and I will share the poll results. So it looks like the majority of you all have looked at this data in some way, shape, or form. 85% said they've used it. If you haven't looked at it on the website, as was noted from Rolf earlier, definitely check out the washdata.org and take a look at that. And then secondarily, how did you utilize the data? Number of folks are using it for background reading as expected. That's certainly one of the ways in which I use it, but folks are using it in their proposal development through advocacy. Some are even using it in research, implementation, a few to help develop monitoring systems, and 6 of you said that you used it in other, and I would love to know what that other is as I was coming up with this list of possible ways to use the data. So if you're one of those 6 people who said other, please write in the chat what you were doing. So I'm going to open it up for folks to give comments about this. I'm first going to turn to my colleague Habib to start off on how he's looking at using the data, but then certainly open up to others who want to comment. Habib, if you want to come in here.
Hi, thank you, Lindsay. Thank you, Rick, for that comprehensive, information on the JMP data. And I just picked a few things in terms of just the poll that you shared, Lindsay, on the number of people using that information for implementation. And also that this data, before we see it, before it becomes relevant for JMP to share, has to cover about 30% of the country. So it means there's a gap in terms of how data is utilized on the ground. So I just want to talk about a platform that's been developed by the Global Water Challenge, and which looks at comprehensively bringing these data sources, making it available, compiled on the platform that people can share data and have access to, kind of a centralized data source. But more importantly, to be used for implementation on the ground by districts and facilities who have this type of information. And this information is being used to, one, understand more granular district and regional scale. And it's built on the JMP core indicators. So it's aligned with the JMP core indicators and also WashFit survey questions. Presently, we are exploring case studies in 3 countries, Ethiopia, Ghana, and Uganda. But we are open also to sharing, to other countries sharing their data with us. So the main goal is to develop a set of decision tools that can be used to visualize the landscape and also optimize investments. And I'll put that information, that website information, in the chat, and people who are interested can reach out to us in terms of that. So we have where, generally, we can see these things. People are looking at globally, and it's very important because it's important for advocacy. But how can we use this type of information also on the ground? So if you have, very few information that's been gathered, but even if it can be used for actionable implementation, I think there should be opportunity to use that also on the ground. Thank you.
Fantastic, thank you, Habib. So that's an example of using the data in more localized sense, and certainly using the indicators, which I think are critical. I'm curious here if other folks want to raise their hand or unmute themselves. Those of you who said you're using it for advocacy purposes, for example, how might you be advocating with the JMP data? And this is a community practice. I know you all. I will call on you if we keep silent. Anyone using it for advocacy? Or research? Oh, we got a hand. Great. Martin, please go ahead. Thank you.
Thank you, Lizzie. Actually, in engaging with the folks mainly at the district who are implementing, the JMP data is very handy, especially on when we were advocating for at least raising service levels to basic services. and they are able to see what it entails. So recently we had an engagement with one of the districts talking about using the root cause analysis approach to look at the poor wash in healthcare facilities. So we use the JMP data to show that this is actually a global issue, and they should not be left out as a district, but at the same time, it raises also the kind of concern that this is not only maybe IRC supporting the district to raise, but everybody or many people are concerned globally, and the data was very handy to make such a kind of appeal.
That's fantastic, Martin, and that's really helpful to hear. I think being able to show that it is not just you advocating, I'm sure is valuable, but also to demonstrate that they're not the only ones in this situation. I think there's something to be said about not pointing fingers. And this data demonstrates that many facilities across the world are looking at a similar concern, and that we're all trying to move this forward. Do we have other comments? I see a chat box comment about the other. Olufemi is talking about using the data in her lectures with postgraduate and undergraduate students, which I think is really interesting. And the fact that I come from Emory and did not mention that is telling that I am not a professor. But I think that's a great way of really demonstrating here to future practitioners where there are gaps and where they could their expertise could be valuable. We have other thoughts on how we use the data, perhaps for proposal development. I think that's one way personally I've used the data is writing down where we are in terms of the status and why this issue is critical. But are there other thoughts on how it's been used? I know I've got some UNICEF colleagues on here who I'm certainly hoping are using the data excessively in their work. Anyone from the country offices who are utilizing this data in your conversations with governments? We also have, personally, I look at the HMIS system as a system that we really want to be using to get future data. And so advocacy there as well in terms of the conversation around what indicators might exist for HMIS. Anyone else from our USAID colleagues of how you guys are leveraging it on these projects? Or our researchers, Darcy, Matt, anyone? Got a shy group today. All right, well, you have a second to drop any other comments in the chat. I think this has been really helpful, Rick and Tom. Thank you so much for presenting on this data. Personally, I use the JMP reports in everything I do. I think the data is really valuable to set the stage, to understand where gaps are. And I think certainly from an advocacy perspective is a priceless database that we really continue to leverage further as more data becomes available. So I will then close it up here. I'm going to pull up a couple more slides just to share where you can find more sources on washinhcf.org. So if you're not familiar with this website, I encourage you to go to washinhcf.org. This is where you'll find a number of resources. It's also where you'll find our website. washinhcf.org/COP is where you can find recordings from this event, as well as previous events. You can subscribe to our listserv. Please send us topics recommendations. This topic actually came from our steering committee and colleagues actually from Nigeria who said they felt like the JMP data was being underutilized and that the community really needed to better understand what was out there and how we can use it. You can also nominate a success story, and will take place, sorry, this says September. This is going to be March 2023. There'll be a next session on environmental cleaning, actually. So those of you who are interested in the conversation today around environmental cleaning, that will be our next session. Again, the website, washinhcf.org/COP. Rick and Tom have dropped a number of resources in the chat around the JMP. I highly encourage you to take a look at those. And please feel free to let us know if you have any questions. Shantia, I'm going to let you have the last comment here.
Hi, Lindsay. Sorry, I was with my girl, the baby, so she sleep on that. That's why I cannot when you ask about the like country official something about our question, I want to now I gave her to her my husband. Sorry for that because with a baby now I just have a baby.
No problem at all.
Yes, from 2021, after we had country consultation for was in healthcare facility with MOA and NIS. I think you was in Cambodia, you know about National Institute of Statistics. So I used that channel to push MOA. So now it seems like MOA agreed to put kind of was in healthcare facility tool in HMIS in the health coverage plan. So now I'm working with the Department of Health Planning and Health Information that Dr. Rawat, I think you might know him, that we're working on that, and also with the WHO colleagues here that Dr. Debbie. So yeah, we try to advocate that. But now I did discuss with the technical department, Dr. Sokson and his team. We have revised the tool. Then I share with the group, and now Dr. Sokson his advised that we need to have the like consultation with the health partner to see that the tool proposed from the technical team is it appropriate to put in the health coverage plan before we document and share, send to the high level for endorsement. So it's for your information, but a lot of work need to be do more on that. Thank you.
Fantastic. Thank you so much, Shantia, for taking time away from your family to speak to us about this. And absolutely, I think using the JMP indicators as a place for conversation around integration of HMIS and discussion about how we integrate this into national monitoring systems is critical, and certainly using the existing database as an example of what kind of information we can be drawing upon it. And so you can go back to the reports that the JMP has put together to showcase how we're doing some of these analyses and some of the disaggregation of data to really understand the gaps in global information, but it also could be very useful at a national level. And certainly then feeding back into the global reports to Rick and Tom for their team to be able to say, this is what's happening globally for Washington healthcare facilities. So again, I want to thank all of you all for joining. Thank you so much, Rick, and then Tom for also participating. We are doing a second session this evening. So for those of you in the Asia and Pacific time zones, you have colleagues out there, let them know that we'll have another conversation on this. All of these recordings will be posted in the next day, and we'll send out an email with the resources, including the specific links to these documents. So thank you all for now, and we will see you in another 2 months. Late March, we'll be having a session on environmental cleaning. Take care, all. Leave it open in case anyone has any questions, and then we'll close on up. Thank you to my interpreters. They've been fantastic as always. Thank you, thank you, thank you. Lovely.